please keep introducing yourself in the chat and talking with each other. I'm very, very glad to have you all here as we talk about partnerships and the community-centered health home model. Quick disclaimer, this activity in the council is funded with a cooperative agreement by the Health Resources and Services Administration. This project is through the American Rescue Plan, but the content of the presentation is not necessarily endorsed by HRSA. If you are unfamiliar with the council, we're a membership, training, and advocacy organization focused on supporting those who provide care at the intersection of health and homelessness. Our mission is to build an equitable, high-quality healthcare system through training, research, advocacy, and the movement to end homelessness. I'm really excited about our presenter today, Julia Liu from the Asian Health Services in Oakland, California. She is recently the Chief Executive Officer, I believe, as of January, that promotion. So again, congratulations. To hear about the work that Asian Health Services has done to create systems level change in their community. Our learning objectives today, just quickly to be able to hear about the work that Asian Health Services are doing, think about potential partners in your own communities, and how you can kind of think about assessing services in your community. As we get started, I just want to take a moment for all of us to think about why we're here today. What drew you to a conversation about building partnerships? I'd love to hear from you all in the chat about some of the motivation for being here today. Maybe you're interested in figuring out how to take the next step in addressing social determinants, or maybe, you know, there's just resource or capacity issues that you're facing and you're trying to think about how to address need when you can't necessarily provide those internally. Maybe you built some new relationships in response to COVID, or you saw some needs in light of COVID that you are hoping that you can either sustain or build upon. Or maybe you're just trying to figure out how to better serve folks who have complex health and social needs. So please, again, feel free to type in some of the things you're seeing and what you're interested in the chat. Linkages to care and referral, closing the loop. Feel free to continue putting your thoughts down, and love to hear from you. And there's a lot of different ways that we and communities can address some of these needs, and potentially a lot of different players involved as we're thinking about addressing healthcare needs. And each of these can be a barrier, and different systems and navigating all of these different pieces can really be challenging for folks who are just trying to thrive. But with each of these, there is an opportunity to have a more coordinated approach and look at systems as a way to improve individual and community health. The model that we're highlighting today is the community-centered health home model. It's created by the Prevention Institute. I'll add a link in the chat in a moment, but you're going to see this slide again from Julia's perspective. To just think about this, a strategic way to identify causes of health issues in the community, and also build partnerships to address those that issue at a systems level. Please, again, feel free to add questions, thoughts, comments in the chat as we move forward, but I'm going to go ahead and hand it over to Julia.
Great. Well, thank you so much, Lauren, and thank you for having me here on this webinar. And it's a pleasure to meet you all. It's wonderful to see folks from Tennessee, Iowa, from my own state here in California. So it's again a real pleasure to be here. And Lauren is so gracious. She's going to be helping me to move through my slides, so we can go to the next slide. You know, when Lauren asked me to do this presentation about social determinants of health and partnerships and I reflected a lot on the term of social determinants of health. And I think that we've all been through so much because of COVID. And, I think it's been almost 2 years. And so there's just been a lot. And I think that we have faced quite a lot. So, it really made me think of when the term first kind of came onto the scene over 2 decades ago. It reminded me of an article that Atul Gawande actually put out in the New Yorker, and it was called The Hotspotter. And it was a piece that actually sparked a national conversation about the social determinants of health. And actually, it was a debate about whether or not tackling social determinants of health was truly an effective approach. Because when we were thinking about all the amount of energy and resources that goes into addressing these aspects, does it really actually impact one's health when it came to ER visits or hospital readmissions? Just an overall sort of debate ensued. Next slide. I think it became pretty clear, especially during COVID. We saw that social determinants of health, the conversation kept going about how these factors, these root factors of health, really spoke to how we move the dial on health equity, given the significant disparities that we all saw that were exacerbated during COVID. Kaiser developed an entire playbook focused on social determinants of health. CMS actually issued a whole roadmap for states talking about social determinants of health and how that actually supports value-based care strategies. Next slide. So really, in thinking about social determinants of health in relation to social needs, especially during this time, really this visual talks about how we have been really effective on individual impact. But when we think about the broader community, it's really about how do we shift upstream to create community impact. And as you can see, in order to achieve community impact, really, and to move upstream, there is a need to think about the strategies focused on improving the community's conditions, and also tactics to actually shape and pass laws or policies, or actually creating the conditions that support our community's health. So this is in contrast to midstream, where oftentimes it's about impacting an individual, whether it's screenings, it's community health workers directing assistance to meet patients' social needs. So really, this is about kind of thinking beyond that, and how do we push beyond the four walls to really address community health. Next slide. So with that in mind, as Lauren had presented the CCH model, really around sort of the components. So really this model consists of sort of foundational and functional capacities that are needed to spark and inspire and support healthcare organizations on being able to shape and impact the health of the communities that we serve. And so really, in terms of thinking about healthcare's role in addressing social determinants of health, this model has been helpful in really thinking about what are the components from leadership to partnerships to the staffing and knowledge and skills that are needed. There are many models out there in healthcare, and really always the question is, wow, is this just another thing we have to do on top of all the things that we're doing? And especially during COVID, everyone is tired, everyone has fatigue. And so how do we really think about this, in a way that really actually is a way of how we conduct business and is built into the DNA of our work. So next slide. So really, when we think about this community-centered health home model, really it's about not only acknowledging the factors outside the clinical walls that affect our patients' health and their outcomes. It really is about how do we actively participate in improving them. Next slide. So just a little bit about Asian Health Services. We are a federally qualified health center located here in Oakland, California. We serve the underserved API immigrant and refugee population. We have nearly 30,000 patients with 500 staff, and majority of our patients are under the 200% federal poverty level. We provide medical, dental, behavioral health services for all cycles in 14 Asian languages. And we formed in 1974 with UC Berkeley students who were activists and who saw the need for affordable healthcare in language. During COVID, we have really provided tens of thousands of vaccinations and COVID tests, and have been on the ground and on the front line, just as many of you probably have all been as well, in really trying to address and meet the needs for our community during this pandemic. And so what I'm going to do really is about talking through 2 examples of how we utilized the CCH model. So I'm going to go through 2 examples. So really quickly, this is a picture of the streets in Oakland, Chinatown. This was years ago, but I show this because what happened in our community was that we had an older gentleman, Mr. Hong Yi, 86-year-old, and he was crossing the street and he was actually hit by a car. And this picture depicts the situation of, we had seniors, we had children who were constantly crossing the street, but always in conflict with our cars. So next slide. So Mr. Hong Yi was crossing the street and he actually was hit and he was killed. And that was right in front of our clinic. And so we started to look into this issue a little bit further. And what we started to unearth was that our neighborhood had the highest rate of pedestrian and vehicle collisions. We knew that 1/3 of our community were seniors. And at the same time, because we were also a commercial district, we had over 20,000 shoppers, tourists, and visitors who were coming every weekend, and about 14,000 cars on a daily basis who were actually going through our community to get to another city. So we were situated and our streets were designed in a way that promoted a lot of traffic through our community. So next slide. So I think that what we started to, as we started to dive into the issue a little bit more, and started to recognize that not only did we have these pedestrian accidents and collisions, when we looked at the state, actually, we had one of the highest number of deaths and injuries. And so it was not something that we felt that we could ignore, because we had many patients who were coming to our clinic, and we had many of our residents who were walking in the neighborhood. So we got our youth department to actually start to collect data. So they took pictures, they timed the streets, they started to map out all of the observational data, and they put them into, you can see our 2 youth put them into posters of describing what the issues were. And we actually presented this to our local city council. And so we actually brought forward a lot of data to educate our local policymakers and community members. And we started to brainstorm on what are some solutions, because what we started to recognize was that this truly was something that we needed to come together, not only as a clinic, but as a community, and bring our policymakers into the loop about it. So we worked with the city council member who brought forward the engineers from the city to think through some solutions. They saw that in Washington State, they had implemented what were called scramble systems, 4-way crosswalks. And so we actually thought we should pilot this and implement this. And so we worked very closely with the city on figuring out how to do this. Now, Department of Engineering and Traffic pushed back. They said this is too much of a liability. This has never been done before. But we were able to organize our patients and our community members to actually attend and really push this forward. Next slide. And so what actually happened was we began to really fashion what was a community campaign. We actually called this Revive Chinatown. So this initiative became a larger aspect of, as we started to dive in, we realized, not only does our community experience these pedestrian injuries and deaths, it was also that we started to recognize that our community was also facing a lot of inequities. And so this campaign, it grew out of pedestrian safety, but really it was about bringing together a vision for our community in the future. And so we brought in local architects, we brought in our different commissioners on the planning commission at the city. We brought in our patients, we brought in all the residents, and we started to really think big about what is it that we need here in our neighborhood in Chinatown. As you can see, we had architects who drew out the vision, and we recognized that actually Chinatown, in looking at our streets, was the victim of poor planning and neglect by our local agencies. And it was traced all back to a history where streets were designed, where actually local Chinese could not cross the streets, certain streets in Oakland. And so we realized there was a design history that related all the way back to several hundred years ago, and how, again, our environment, our planning environment was designed. So again, we started to take a more perspective on community conditions. And we saw the real opportunity to address social, economic, and environmental factors for our community's public health. And so as we started to do this, we began to forge partnerships with the city of Oakland, and we started to ask for these changes. So next slide. So we did all this planning, and we started to work very closely with some of the city staff. And we asked about some funding opportunities because we didn't want a plan to sit on a shelf. We brought in all of our community members into a big process with experts around the table. And now we actually wanted to see how we could get this implemented. So we actually worked very closely with the city. We're able to identify a way for this to be capitalized. So we pushed for this to be budgeted in the city. We asked for some grant funding and support. So we worked closely. We asked for a grant writer from the city. And so we put together a grant proposal. And we actually got $250,000 to actually implement our plan. And so this is just part of what you could see. We realized this was an opportunity for us to also establish our community identity. We never had any type of gate. Chinatowns usually have a gate, but we had signage that we worked with our Bay Area Rapid Transit to notate, different institutions throughout the neighborhood and community. And we got street lighting, which also played to public safety, because we had heard it's so dark on the streets and people were not comfortable walking along the streets to visit businesses. Next slide. And so what we ended up being able to implement was this full 4-way crosswalk in 4 main intersections throughout our neighborhood. And through our planning process, we heard from our community, we also want our community's identity. And so this 4-way crosswalk, as you could see, is actually a Qing Dynasty pattern. People felt that that really resonated with identity for their neighborhood. And even through the signage, it was a Qiling, which is a good luck animal, both in Chinese and Vietnamese communities. So really it was about bringing together all of these partnerships all along the way from the city. We worked with our Chamber of Commerce around the businesses. We worked with our rapid transit, and it was coming up with a plan and actually trying to fund it. We were able to see that actually this 4-way crosswalk improvements were able to actually affect pedestrian safety, and saw that we had pedestrian injuries decreased by half. And actually this became a model for other communities throughout the Bay Area, throughout our county and other neighborhoods throughout the state. And really, it helped to foster community identity and show to our patients and our community members, we really value your vision and your thoughts, and we can bring them to bear through these partnerships. The next slide. So I think really, when we think about how we address, an issue and then look broadly at the factors, it really is about addressing health equity. I think that is the heart of the CCHH model, really making sure that every individual does have a fair opportunity to achieve their health potential. And we see that especially within COVID. And so I wanted to just bring to you one other example of how we use the model as well. Next slide. So, many of our patients, we have a large Vietnamese population, also work in the nail salon industry. And we saw that during COVID that within the Asian community, there was a lot of unemployment and that a lot of our workers in these industries had lost their job and had to close down. These are a lot of mom and pop shops. And as we, saw this, next slide, we also recognized that they were also facing a lot of health issues. They were coming to our physicians saying that they were experiencing health symptoms. And what we started to realize when we started to do more outreach was that pretty much every nail salon worker was experiencing some kind of health issue. And again, it was really taking this model of like unearthing and surfacing what are really the root issues around this. And we realized it was a lot to do with the chemicals that these workers were handling. And we saw that this was predominantly female immigrant industry who are of reproductive age. And so we recognized that actually we needed to, again, bring in more partners to start addressing this issue rather than seeing them in the clinic and saying, well, go ahead, this is part of your work. You need to decide whether you want to stay in this work or not. And so we created what's called a collaborative. It was the California Healthy Nail Salon Collaborative. Next slide. And so what we did was we started to, again, kind of similar to our pedestrian safety model, really gather together our members to really hear what the issues were. And so we began to bring forums. We brought our state officials to hear what the concerns were. We wanted to understand what they could do to enable worker safety, and especially for our patients and our overall community. And what that led to was a clear ask by our local counties around worker safety protections. And so you can see some of our patients and our nail salon workers who actually went to testify at local hearings around what they wanted to see. Next slide. And so ultimately, what we did is we created really a process where, again, as we gathered our patients and our community members in the nail salon industry together, really training them on how to assert their rights. Our mission is both advocacy and services, and we felt that we wanted their voices to be heard and in their own language. And so as we brought them to our city council, to our county, we pushed for legislation asking for worker safety protections. And we engaged some researchers from UC Berkeley, from different entities at the time, and the Cancer Prevention Institute, to really look at how to articulate, all the needs in terms of data. But overall, really, what we did is we were able to pass at the state level what's called the Healthy Nail Salon legislation. And this was to really support salons in being able to provide services with healthier products that were out there and to be recognized for it. So it took a lot of, again, cross partnerships that we pulled in where we had gaps, whether they were researchers or policy advocates or our local and state departments, and holding them accountable to some of the issues that we, again, were seeing among our patients and community. Next slide. And so I think the question has always been, well, how did we get from there to here? And so, again, it's always a question about capacity. And I think that next slide, I came up with a few points of how we sort of thought about it. And I think the number one thing is really around a leadership commitment. We have a mantra here that our success is not just in the number of patients that we serve, but the number of patients who can actually assert their right to healthcare. And so there has been a commitment to ensuring that our patients' voices are heard. Next slide. Number two, we learned that it was very important in how to redefine the problem. So oftentimes, we found ourselves defining the problem at the individual level. You could say pedestrian safety, that's something that an individual, they need to be careful when they're crossing the street. Or for the nail salon worker, you need to be careful when you're at work and handling chemicals, but it's up to you to make that decision. When in fact, really the problem itself was really around defining this as a community issue. And also, how do we push this to thinking about how policy can actually shape an outcome? And so again, how you define the issue then will then lead to how you can promote engagement on multiple levels. Next slide. And it is about reshaping the narrative, because the example for pedestrian safety, it could have been defined simply as pedestrian injuries and fatalities. But again, if you take the factors, social determinants of health factors, then the narrative could be shaped to how our community was disproportionately suffering from, one, transportation burden. There was violence and crime. Our businesses were declining in economic vitality. We had all of these cars just coming through our neighborhood. And at the same time, our patients did not feel safe to walk in the neighborhood, and predominantly had disproportionate diabetes, chronic illness. And so it all led to a larger narrative. The next slide. And that, in a sense, once you reshape the narrative, once you redefine the problem, is how then you can engage in diverse partnerships. So that is where we started to see, when we saw we bear a transportation burden, that was where we need to engage the city of Oakland and the traffic department, and finding how we can work with them. And we needed funding. So we asked the city, and our council member, please work with us. Can we have a grant writer or someone who's looking at your grants to please engage and include our community? Next slide. And I think a very important part is involving the patients and the community in your problem solving. When we held those forums, we heard a lot more than what we saw from our own perspective. We heard about the businesses were in decline, how many of because of the traffic, people didn't feel like they wanted to shop in our neighborhood anymore. They wanted to go somewhere else where there are huge parking lots. So I think that, again, we started to hear the problem that started off as pedestrian safety. It started to actually help us really understand more of what is the community issue at hand. Next slide. And I think what was really important was about finding champions. We were very lucky to have a council member who was going to be our champion. When our youth came to speak, he actually said, we need to do something about it. And he became an immediate partner. With our nail salon workers, when we approached our county board of supervisors, we also asked, please help us think through how we can actually create a program that supports our businesses, but also the workers. So champions are very important. Next slide. And then lastly, I just want to say that, it wasn't an easy thing to always do. These initiatives took years. But it was also about, sometimes we didn't have a seat at the table, but it is about, if you don't have that seat, then how do you build your own? And I think we built our own because we created the forums, our own community forums. We created our own fact sheets that we would bring forward to our policymakers. So I think that in many ways, it's not just building your own table, you've got to build the house. So when it doesn't exist, you create it and expand the playing field. Next slide. So I just want to end by saying, again, this CCHH model, really, when we think about it, it represents more than just a one-time effort. It really is about a cultural shift on how we can think about our role in improving our community's health. And I think that ends my presentation. Really thank you for this time, and put my information here should you ever want to reach out, and really happy to answer any questions so far.
Thank you so much, Julia. Every time I hear how the CCHH model is used, I am just always more and more impressed at kind of the level of commitment that your organization has to making real community systems level change, but also just looking at these two different examples, just how kind of versatile the model is and how we can really use it to address root causes. So I thank you for taking the time today to share the work that your community has done, and how your health center really led the charge on making these changes that are really improving community health in the way that we define healthcare, but also just kind of the vibrance and the way a community can thrive. So I really appreciate that. And I see that there's some good positive feedback on kind of how public health is part of this in the chat. And we have one question that's come in, or kind of a two-part question that's come in so far. So Elena is asking, kind of, to implement the model in a health center, what does that team look like, and kind of what staff or department has spearheaded this work?
Mm-hmm. Yeah, that's a great question. So at our health center, there was a team. We have a planning and development department that supported some of the grant involvement and the funding. So when it came to the city, and we asked for their expertise as well, so that it wasn't just us. And it was really a great partnership. And we had asked our council member to assist with that. With regards to implementation, it really was many members of our leadership team. It was our CEO. At the time, I was a director, and also folks from our community outreach team. So it involved many different levels of leadership, but also folks in our community outreach department, because again, they were hearing a lot of issues, but and how did we bubble that up? And then we helped to then create the meetings with the policymakers, and also sort of the thinking around how do we design our community forums. And we did engage some consultants, because this was new for us. And so we didn't know about transportation. We didn't know about urban design. And so in that way, we did engage some of our folks who were on the planning commission, and they volunteered for us because they knew that we needed the expertise. And so we created a kind of almost an advisor group as well, who helped us really think through some of these aspects of how we can get over some of the hurdles to actually creating change.
Great, thank you. I had a quick question, and I was just wondering if you could talk more about kind of the role of your community and like patients at your clinic. We talk a lot at the council about kind of the role of the consumer voice and the consumer advisory boards, and I'd just love to hear more about kind of how you engaged those individuals in this work.
Yeah, so we made a commitment because, again, because of our mission of both advocacy and services and making sure that our patients are engaged in that, we have created patient leadership councils. So we have patient leadership councils in different languages, and pre-pandemic, we were meeting monthly. So we did have a community outreach team who was focused on engaging this council And, when we first started, we started very small. We had one group, we asked our providers recommendations, maybe of some patients who might be interested. We put it out to the community. And so monthly, it was about both is a bidirectional. We had a lot of patients say, I just want to know more about how to, call the police department. What happens? Who's the fire department? How do I engage them or when I need them? And then we would also teach them about what's the policy process. We would also teach them about, how you can, manage your health conditions, or, how do you actually reach out to your fellow community members. And so we started to build a curriculum around that. And then every 18 months, again, pre-pandemic, we would engage our full patient membership. Usually we had 500 patients show up, and we would actually have a forum with them to hear from them, what are their issues, their needs, and we would bring our local officials to hear directly, not only say what are they doing for our community, but also for them to answer questions directly from our patients. So, we have done that, and we use that as part of our overall of pushing community change. And I think there's a question about the topic, empowerment, skills and knowledge, community power, and some virtues. Do you mean, do we include those in our sessions with our patient councils? Oh, okay. Yes. Yeah. So we do talk about, empowerment, but we have to do it where our community and our patients are at. And so we actually break it down to how to tell your story. And then we start to build on how you tell your story. What do you think are the issues you are seeing? And then really breaking down what does it mean to have an ability to share your story and your issues to, let's say, a policymaker, and understand what is the policy process. Our patients actually come from countries where they were punished for speaking out. And so that was not something that they wanted to do. And so we actually built in a process where we described, here is what, you have an ability to actually, and the right to actually push on policy change that you want to see. And so it just takes some time, and every group is different. Our Chinese group compared to our Vietnamese group to our Korean group, everyone has different histories. And so we work with them in those capacities and really think about these nuances. And for equity, so we have been actually also started to think about how do we address health equity. And we have been incorporating the notion about, as we are all experiencing, sort of the different things around racism and recognizing racism as a public health issue. And our community has been facing that. And we recognize that we want to bring that aspect in. And then also just around health equity in general. All of the different, again, disparities that our community has faced, especially when it came to accessing vaccinations or COVID testing. So we started to actually address health equity from a data perspective of making sure that our communities were represented in data. So I don't know if that's helpful, but that's what we started to integrate and implement.
Thank you. And I think we also have a raised hand. I will unmute you real quick, and if you wanted to ask any additional questions, you are welcome to. And I see a couple other questions. So one is, can you talk a little about the root cause analysis and what that looks like for you?
Yeah, I think that how we have done it, and it hasn't been, completely systematic, but when there has been an issue that comes up, what we do is we actually start looking back at from the patient perspective and then also from a data perspective. And then hearing it from not only our community health workers, our providers, but then also, again, just taking a look and a step back from more of our data. So pedestrian safety was an example. When that happened, we recognized that it was in our community and we saw the issues, but again, we took a step back to look at, well, what is the data at the local level and then at the state level? And then we started to build our narrative as we started to, again, see more of the issues of how it started to play into a need to engage our local policymakers. In terms of the evaluation, if you mean the evaluation of the project, that was, again, something we put out as, for help from our local universities. So, we always have talented students who want to do internships from the public health school. So we would engage them in that process and then work with our public health school to do some of the evaluation around this.
Yes.
Oh, Lauren, I think you are on mute.
I muted my phone, not the computer. Okay. I had one more quick question for you, and that was just thinking about building partnerships. A lot of times we hear kind of how do you get buy-in from those other partners? And I know you all collected a lot of data. And so I was wondering if you could talk a little bit about what you found as kind of a compelling reason for them to work with you and what you found as a good way to approach those conversations.
Mm-hmm. Yeah, I think what was really helpful for us was when once we understood the issue and more beyond sort of the individual and really took that model and did that analysis, I think it became more clear of how we envisioned whatever partner we were asking, pretty concrete of what we felt like was the need and the issue. And I think that oftentimes, let's say if it was another community-based organization with policy expertise, I think that we would start to engage on, this is what we need, what do you need? And then it would start a conversation of, well, it looks like maybe we need actually some funding for this and support because all of this does take time. And so that conversation would start and then we would say, well, let's meet with a funder. Here's a funder we think would be interested. So some of our local community foundations, and that's where some of the data again came in. And again, if it was aligned with the partner, I think that really helped. Again, when it comes to like the city or the county, it's more about holding them accountable. It is about bringing that data and saying, actually, we need you to help us because these are the issues. And, we see that you need some shared responsibility in this. When it came to researchers or other folks, again, it was really about, oftentimes we would just have a meeting and just explore. And I'd say oftentimes more than not, the people would say, you know what, this is a really important issue that we're also trying to address maybe from a different angle. And so that would really invite a collaboration. And again, it could be collaboration on many different levels. So whether that it could be just, we're just supporting you, or, oh, we want to fully engage. And so we actually started to define different levels of collaboration so that people didn't feel a pressure or they felt like they could engage in some way, but we could still really call that collaboration. Let's see, I think, is it Athens asking, is there a special, excuse me, software? We did not. We did not have any specific software. Really, it was collecting data from local county, looking at there's usually, at least in our county, we have a county health assessment. And then there's other data that's out there. And then we created our own surveys. And really you can do them with your patients, when they come in for your visit, or so we do those type of surveys, and it could be a short survey, and put that together. So we didn't use any specific software or anything.
If you have more questions, please put them in the chat. I've got a couple of quick announcements as we wrap up. And so we can always revisit those before we close out if any burning questions arise. But first of all, I just want to thank you again, Julia, for sharing the work you're doing and taking the time to talk with us. I really appreciate it. And I am a big fan of this model, and it's just so great to see how you've implemented it. For folks who are listening in and are interested in doing more with the community-centered health home model, we are working with Prevention Institute on a learning collaborative. So you can think about how you want to implement this in your own community. Applications are open until the 25th. I put the link in the chat. You can also email me if you are interested in more information on this. If you want to try to implement something much like Julia did. And then the council's conference is happening in May. Hopefully we'll be in Seattle. So hopefully we can be all together for this. And we'd love to see you there. I will put the link to the registration in the chat as well. If there are no other questions, I will let you all have the rest of your Friday. Thank you all so much for joining. It's been really great to have you all chat with us today, and I hope that you have a wonderful weekend.
Great. Well, thank you for having me, and please reach out if, again, you have my email, and happy to share more if needed. Thank you so much.
Thank you. Really appreciate it.